It's 7 o'clock, so we might start. Thank you so much for being here. My name's Karina. Just a little housekeeping first. I'll just ask if you could all stay on mute. By all means, show your video. It's great to see faces, but yeah, if we could just stay on mute. If you do have any questions that come up, please put them in the chat. So if you don't know where the chat section is, at the bottom of the screen, there's 3 dots, and you can click that and it will open up the chat for you. So at the end of this, towards the end of this session, we'll try and answer some questions if anyone has them. And we do have a pretty packed hour for you, but hopefully we can get through it all. And if we don't get to your question, we'll try and answer it afterwards. So I just want to start off by acknowledging the traditional custodians of the various lands on which we work and meet on today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. So I'll just give you an overview of what we're going to do tonight. So I'll share my screen and you can see, yeah. This is the agenda for tonight's meeting. Just starting off with a bit of a welcome and introduction. Professor Hawke's going to take us through an overview of MS treatments. We have a few questions on MS and COVID. I'm going to speak on fatigue management. Professor Hawke's going to speak a little bit about the research that he's been involved in recently, and then we're going to come to the questions and answers. So I'll start off just by introducing myself a little bit. My name's Karina. I have met a few of you, but for a lot of you, I'm just an email or a voice on the phone. I am originally from Lithgow, so I'm from the country, grew up, born and raised in Lithgow, went to uni at University of Sydney, and I've been a registered nurse for 10 years now, and I've been working in this role of MS nurse since the beginning of last year with Professor Hawke and the patients at Central West Neurology. So why we're doing this webinar, it's a bit different. This year I'm undertaking some research into what is unique in the regional people living with MS, what is unique for those that are living in regional or remote locations, and looking at ways that we can improve any disadvantages. And so I just wanted to share with you a few of the findings. Thank you so much to everyone who's returned surveys, whether it was online or through the post. I really appreciate it. We have just under half of all of the MS patients that we look after. So it is helping us have a better understanding of what it is like to live with MS in the Central West. So a few of the findings, most of the people surveyed have had MS for more than 10 years. So there's a whole range of people, but I thought that was interesting. Another interesting point is that there's a lot of people that are on a range of treatments. Some people aren't on any treatments. So it'll be interesting as well to hear from Professor Hawke about the rationale behind why certain treatments are suggested for certain people based on what's happening with their own journey. I thought it was interesting. 80% of those surveyed are interested in MS research. I'm sure the question we all want to know is there a cure yet? But I know that there's a lot of MS research that is very interesting and very relevant to you, I'm sure. Another interesting finding that we found from the surveys was that more than 50% of people living with MS in the Central West don't have contact with anyone else that has MS. And more than 50% of people surveyed do feel that there's some sort of disadvantage because of your regional location. So this is why we've started to send out newsletters, as well as hosting this webinar, because, you know, Professor Hawke or Dr. Blackwood, they are your neurologists. So you already trust them. So it's information coming from someone you know. And also, we just want to try and do what we can to bridge any gap, or find out what you do feel is disadvantaging you. So hopefully you find tonight helpful. I will be sending out a recording afterwards so that you can watch back, or even share it. I know there's a lot of people who wanted to be here tonight, but weren't able to make it. So the recording will be made available. So hopefully it's a resource to you. And also, it's amazing to see, you know, that even though living with MS, it's like an invisible disease, you can see that you're not alone. Here in the Central West, there's other people there. And so I think just seeing this helps us understand that, you know, you aren't alone in your journey, even though it's very different for everyone. So there are a few of my findings from our survey so far. I'm now going to hand over to Professor Hawke to give us an overview of MS treatments.
Okay, thanks, Karina. Can you hear me?
Yes.
Good. Welcome, everybody, and thank you for joining in. And I hope everyone who looks at this, the recording, will also find it useful. So I'm going to start off by talking a little bit about the treatments in MS. Now, it really is quite extraordinary. Perhaps you could put the first slide up, Karina. Is that possible? How many drugs that we have available. So this is a list of all of the drugs that we have. And you can see that interferons came in the early 90s. And ever since, there's been a sort of succession of new agents, not necessarily of increasing effectiveness, but quite different mechanisms of what the drugs do. All of them, however, are targeting the immune system, because that's the hallmark of MS. The immune system is overactive, and it's crossing the lymphocytes particularly, which are the cells that of the immune system. They're crossing from the body, from the blood into the brain and causing damage. And that's what we try to reduce. So all of these drugs have their theme in modulating the immune system. They're not necessarily immunosuppressing people in the same way that, for instance, if you had a transplant, kidney transplant or a liver transplant, those sorts of immune modulators are much stronger than the drugs that we tend to use for MS. So there are many more drugs in the pipeline, and we now have 14 agents that we can potentially try in somebody who we see for the first time. But I would have to say that when people have had the disease for a while, or in the very small group of people who tend to slowly progress without ever having attacks of MS or much in the way of MRI new lesions, the drugs are not particularly effective. So there's a small group of people who just seem to slowly get worse, and this may be a slightly different condition, in fact. The other, let's have the next slide, Karina. So this is sort of how we sort of think about somebody when we see them for the first time. And we're really thinking of the immune system. Is the immune system attacking the brain in a mild way and infrequent way, because that's the hallmark of MS, that there are recurrent bouts of inflammation in the brain, which are coming from the lymphocytes crossing into the brain? Is it mild? Are the new lesions widespread? Are they very active? Are they occasional? And so we have to get an idea of what someone's disease is like, and that may take a little while. So I'm often thinking that I don't really know whether this particular person's disease is very active, and so it might be better just to hold off and wait and see whether or not, you know, how quickly new lesions are developing. Sometimes you see people who further down the track for the first time, because many of the lesions, as you will know, most of the lesions, in fact, that we see on the MRI scan don't actually cause any symptoms. Sometimes you see people who've developed their first symptoms and they've clearly had loads of inflammation going on in the past. Sometimes people you see with the first symptom and they haven't. So it's very hard to work out exactly sometimes when people first develop the disease. So we have all those drugs and we know an awful lot about them. We're in a great situation in Australia that we're able to prescribe each of them on the PBS, whereas in many countries there are big restrictions on which drugs can be used at what point in the disease. Some countries you have to start off with very mild modulating medication, and it's only if the MS remains active we then escalate. But in Australia, I think most neurologists who see a lot of people with MS think it's better to get an idea about how aggressive the immune system is attacking the brain and to choose the medication accordingly. So sometimes we go straight for quite strong treatment. So that's the bottom line, which says treatment escalation versus high efficacy treatment. Okay, let's have the next one. Okay, that's my office. You'll probably know that if you're my patient. And we do a lot of MRIs. So I find, I mean, we're really quite blessed in the Central West that we're able to do high quality MRIs. And that, might be in Bathurst, Orange or Dubbo. MRI machines, of course, shouldn't be everywhere because they're very expensive. Interestingly, they're on 24 hours a day. So that's something that we don't utilize. They never get turned off. But we have some of the best and the most advanced instruments in our area. And there are no better scanners anywhere in the world, in fact. So having good software to look at them is helpful. Having good radiologists when you're not quite certain what the issue is very important as well. Next one. Do I have the next slide? Well, maybe that's it.
Yeah. Sorry, I don't have the other slide. That was the last one.
Okay. So basically what we do is, because we know that so much of the disease activity doesn't actually cause symptoms, we like to do a lot of MRIs. Now, MRIs are not like CT scans. There's no radiation with an MRI. So you don't need to be worried about having a lot of MRIs. I tend not to use a lot of contrast. Some of my colleagues like to use contrast with every single scan, but I think that's unnecessary. If you can have a look at the scans yourself and make comparisons, and those people who see me will know that I always put the scan up and we look at the current scan and we compare it with the scan that you've had before. And this is how we get an idea whether the immune system is still active and interested in attacking the brain. And that's also how we obviously tell whether the treatments are working or not. So that gives you sort of an overview. I think we're so lucky in this country to be able to use so many very potent drugs, and so lucky to be able to use MRI as often as we think it's necessary. So in a sense, even though people are geographically remote, if you like, from, say, if you lived in Sydney, from a big centre, the distances we're travelling are further. I think that you can be pretty confident that what we do is very similar to what colleagues anywhere else or around Australia would be doing. And I'm whenever I go to meetings, I'm amazed that, when I put up cases and talk about things, that we're all really singing from the same song sheet. And I think that's very important. And that hopefully gives people confidence that, your MS is being treated in, state-of-the-art way. In fact, some of the drugs actually we used in Orange before they were even used at all in South Australia. in the past, particularly, well, that was natalizumab, Tysabri. Anyway, so I think I've probably said enough, and we'll probably have questions and can come back to that. But what do we do next now, Karina? You're in charge.
Yep. So thanks for that, Professor Hawke. We had a few questions just around COVID. So I just thought we'd cover these questions just because, it's so relevant at the moment with the pandemic, and maybe people have had COVID or they might be worried about it. So my first question is, do MS patients need to get the winter COVID booster?
Well, I think that, well, firstly, let's just go back a bit. When COVID emerged, we were extremely concerned because we didn't really know anything about the virus, and we knew that it had significant mortality and morbidity. And interestingly, when it first came out in 2020, it seemed that the most severe disease was due to overactivity of the immune system. And this is something that people with MS will recognize, that often, in the past, you may have found that other people got colds and so forth, but you didn't get very many colds because your immune system actually is very good. I mean, that's one of the issues. So we were concerned, but of course, many people around the world with MS have had COVID and are on treatment. And there's no doubt that the same risk factors for more severe disease exist in the MS population versus in the normal population. And age, of course, is a very important thing, a very important risk factor. But some of the drugs, there was no doubt that people got more severe COVID than with others. And particularly those that depleted B cells continuously. And yet, it was still a very rare event for people to have extremely serious disease. Now, of course, we've got the vaccines, and the vaccines are very protective. Then you come into the situation where some drugs, if you're taking some drugs, you're going to make vaccine responses. Your immune system will respond better to the vaccine than if you're on other drugs. So perhaps the best drugs that give or don't actually have much effect at all on whether you make a good antibody response to the vaccines are those that we don't give continuously. And we have been concerned about people who are on continuous treatment with anti-B cells like ocrelizumab, or on drugs like fingolimod or Gilenya. But having said that, overall, once vaccinated, people usually do pretty well. So the question is, should you have the extra boost? I think if you are on drugs which modulate your immune system, you should probably have the same sort of boosting regime that's recommended for people, for instance, who have more significant immunosuppression, such as, with kidney transplants. But on the other hand, I think probably your risk of severe disease is a lot less, and it will be related to age, but it will be a lot less. So I would recommend people, keep their boosts up as recommended, particularly if they are on immunomodulatory drugs.
Great. So do we know of any long-term effects of COVID in people with MS?
No, we don't at this point in time know of any more serious long-term complications. I think this is a new virus, so it was only really starting to spread in sort of towards the end of 2019. First cases early in 2020 here in Australia. So we don't know, but we already know about the long COVID syndrome, which is like a post-viral fatigue. We do recognize that with other viruses, particularly with the glandular fever virus, the Epstein-Barr virus. not everybody gets it. It's obviously a very common infection. We're now, getting 50,000 cases, 40 to 50,000 cases a day now. But thankfully, most people are getting rather mild disease. But in the long term, we don't know. But I wouldn't anticipate that there would be any major long-term effect of having COVID on MS. It doesn't look like it's triggered worse inflammation in people with relapsing remitting MS. So I think we don't need to be too concerned. Whether there will be an increase of other diseases in the long term, people have suggested perhaps, say, Parkinson's disease might become more frequent. I don't think there's any hard evidence of that. But I don't think we need to be too concerned if you do get COVID, that you're going to have a longer term, there'll be long-term issues. But you're going to ask me about if you get COVID next, Karina?
Yeah, that's my next question. So what to do if you do contract COVID?
That's right. Well, we now have, not only do we have very effective vaccines, but we now have quite effective drugs to actually clobber the virus if you get it. So these drugs have to be given soon after you've got it. So I think the first drug which was seemingly quite effective was a monoclonal antibody that had been developed specifically attacking the virus. So if you get the infusion of this monoclonal antibody, it will basically clear the virus from your circulation. And those patients of mine who have had this, and it seems to have very few side effects. It's a one-off infusion, have felt hugely better if they have felt sick, if they get this monoclonal antibody. Then there are other two antiviral drugs. Now these are tablets, which are also very effective at reducing the severity of COVID. So the government has been pretty good, I think. Basically, I think if someone tests positive and is on treatment and is concerned, then they should go to the hospital, and the hospital staff will ring the local COVID coordinator, who's usually an infectious disease physician, and they will determine if you meet the criteria to be treated. And if you do, you will get the treatment straight away. So presenting, I mean, who knows? Unfortunately, of course, we do wait a long time in hospitals, but I think it's important if you are on drugs, and particularly if you're on the anti-CD20 drugs, ocrelizumab, or if you're recently had courses of, say, cladribine, where your immune system hasn't sort of returned to normality, or if you've had a recent shot of alemtuzumab, Lemtrada, or even if you're on fingolimod Gilenya, you should probably go and have the antiviral. I think if it was me, if I was on any drug and it's available, they don't seem to have side effects. It's a one-off infusion with a monoclonal antibody, and it's a very short course of tablets. I would go and certainly see whether you qualify for it.
Great. If you do have any questions about that, please do pop them in the chat and we can come back to them at the end. So thanks for that, Professor Hawke. We're now going to come to, I'm going to talk a little bit about fatigue management. So in the survey that we did, there were quite a few responses that people wanted to know more about fatigue management. So it's one of the most common symptoms of MS, and I'm sure you could tell me so much more about that than whatever I'm going to tell you. But I think if we have a look at how we can manage fatigue, hopefully it can help you feel that you can get the most out of your energy and do things in a way that you feel better. So the MS Council, I think, to start with defining what fatigue is, for a normal healthy person, they won't understand exactly what you mean by saying that you're fatigued. The MS Council defined it as this: fatigue is a subjective lack of physical and/or mental energy that is perceived by the individual or caregiver to interfere with usual and desired activities. So I'm sure you've had those moments where you feel so exhausted to do normal daily things that you'd like to do. I thought we would start by looking at different types of fatigue. When we understand how these different types of fatigue affect you, then we can look at different strategies for you to help deal with it. So the first kind of fatigue is primary fatigue. And this is that overwhelming tiredness feeling. It's when you feel like you are hitting a wall. It's like it might hit in the afternoon, and it can occur any time of the day for no reason at all. So that's called primary fatigue. There's another type of fatigue called neuromuscular fatigue. And this fatigue is caused by the failure of the demyelinated nerve fibers to conduct messages. So you might experience this fatigue when you're using the same muscle groups for something. So when you're walking or mowing the lawn or even exercising, you might start to feel that you can't continue. Now, this kind of fatigue often resolves with resting. So you might sit down and then feel like that you can then go back and carry on with whatever you were doing. And the third type of fatigue that I want to talk about is cognitive fatigue. And this is exhaustion or mental fatigue to maintain your failure to maintain performance for cognitively demanding tasks, such as studying, computer-based work, or working in a highly stimulating environment. So, for example, if you're trying to have a conversation with someone and the office is very busy and you're trying to focus, that can cause that cognitive fatigue to really affect you. It might also be when you start a sentence and then you don't know how to finish it. That's an example of cognitive fatigue. So if we look at different ways that we can manage our fatigue, then then hopefully managing these types of fatigue are different lifestyle choices. So if we look at this next slide, you probably have asked the doctor, Professor Hawke, or your GP for medication. Now, medication is just one of the different strategies that you can use to manage fatigue. The first type of management that I want to talk about is understanding your fatigue patterns. And you might have a very good idea of when you feel fatigued, or you might feel that, no, I'm just tired all the time. I think it's a lot of people suggest having a fatigue diary. So writing down what time of the day you started to feel tired, when does that fatigue level hit its maximum? Does it come in the afternoon? Do you feel more energized in the morning? Are there any activities that you do that seem to really trigger those different types of fatigue? And when you understand those different patterns of fatigue, then you can start to look at how you are going to manage it. So that's the first step of managing fatigue. So if there's one thing maybe you want to do is you can, get out your normal planner or your diary and write down when you're feeling different types of fatigue. Were you reading a book and then you suddenly felt exhausted? That's a type of cognitive fatigue. So that's an example of how you can understand your fatigue patterns. Then the second thing, medication. So the most common medications that are used to treat fatigue are amantadine or modafinil. And however, there are studies on this which are quite conflicting. So there was a randomized double-controlled double-blinded trial which actually found that modafinil and amantadine were no more effective than the placebo at improving fatigue. And you might experience this. Maybe you don't feel that the medication is working. However, even though people didn't feel that it improved their fatigue levels, the people in this study still preferred to use modafinil. But then there's other studies. A smaller study did find that modafinil is quite effective in improving fatigue for people with MS. So when we think about medications, we do have to consider the fact that there are side effects. And this is why you can't just rely on medication to manage your fatigue, and why we do need to look at other strategies, even no matter how easy they may seem, that it's important to not rely on medication alone to help you manage your fatigue. The third strategy I want to talk about is planning your day. And this can seem really, basic, really common sense. But if you're very intentional with your energy and how you plan your day, you may feel much more energetic at the end of it. So if you have a good idea of your fatigue patterns, then you might be able to plan your day around that. So if you do wake up feeling refreshed, maybe you want to do the things that are most important to you in the morning. You might want to catch up with your friends or play with your kids or spend time with your family in that early morning break or even afternoon. Wherever you feel most energetic, plan to do the things that take up energy. Another idea for planning a day is planning your rest breaks. So rest is very important, but you can even start by planning your rest breaks first and then planning your activities around when you're going to rest. This way you are resting before you are exhausted, and then you hopefully conserve your energy. Another idea around that is balancing your activities. So looking at things that maybe take a lot of energy, such as, washing up the dishes, and then balancing them, taking a rest, and then doing an activity that maybe doesn't take quite as much energy, such as folding the clothes while you're sitting down, or just general dusting. Whatever it is for you that doesn't take as much energy, balance those activities so you're not overexerting yourself. And then talking about rest is as important as exercise. When it comes to managing your fatigue, you need to give yourself permission to rest. And I know for, everyone in today's age, it's the hardest thing to stop. But rest is really important because it means that you are recharging your batteries. And resting means that you need to stop, switch off your brain, be able to just relax. And relaxing will actually help you feel more energized as well. So think about the things that you can do that do help you feel quite rested. And then exercise. We all know that exercise is so important for everything, for our brain health, for our general health. But it also contributes to helping you feel less tired. So the important things when exercising, try to avoid overheating. So you might want to exercise in air conditioning. You might want to limit the time that you're exercising. Don't overexert yourself, and don't exercise until you're exhausted. And try and plan a rest break for after you exercise, so that you do feel that you get that time to re-energize. And then the last thing I want to talk about is communication. And communication is so important because living with a chronic illness can be difficult to articulate what fatigue feels like. It can be tricky to explain to your friends, to your family, to your doctors, your health professionals, or even your employers or your workplace, what fatigue feels like for you. So, and that can, if people don't understand, that can often lead to more feelings of frustration. It can make you feel like you have a low mood. So if we learn how to communicate about our fatigue, it can actually help us manage it better. So I did want to introduce, I've got 5 noisy spoons. I don't know if you've heard of spoon theory. Has anyone heard of spoon theory before? I can't see anyone. Oh, anyway, so spoon theory is, it was coined by a lady who had lupus. So she has a chronic illness, and she wanted the people around her to understand what it was like to live with a chronic illness. And so she came up with this idea of spoons as quantifying how much energy you have. So I've got 5 spoons here. And so you might think in the morning, as someone who has MS, you have 5 spoons, and this is all the energy you've got for the day.
Actually, Karina, do you want to put yourself into the center of the screen, or have you got more slides?
Yeah, is that better? Can you see me? Yeah.
I want to see what type of spoons they were, that's all.
Oh, I grabbed a higgledy-piggledy bunch. So I've got 5 spoons. So this is a metaphor. This basically represents the energy that you have for every day, and every day it feels different. So you might say to if you had a bad sleep, you might want to take away 1 spoon. If you missed your medication, you might take another spoon. So now you've only got 3 spoons of energy. Now, if someone's asking you to go out with you to the shops, you might say, that's actually going to take up 3 spoons of energy. I can't do that today. Or you might think it's going to take 2 spoons for me to shower, and then I need to go back to bed because I need to get more energy. And so, you know, on a certain day, taking a shower might be 3 spoons. On another day, it might just be 1 spoon. But having this, you know, creative way of communicating about your energy levels can help other people understand what you mean when you say you're tired. You probably feel that people, they mean well, but they're like, yeah, I'm tired too. But you're like, no, I actually have a lot going on. So if you think about using spoon theory, it's something you can talk with your doctors about. It can help them understand your experience of fatigue. So I know that was a quick overview of fatigue management, but if there's any other questions you have or you want to discuss how we can plan some strategies, please do contact me. You can always just reply the emails that I send out, and I'd be more than happy to talk about that with you. So now we're going to go to Professor Hawke, who's going to give us an update on some research.
Great. Oh, well, thanks very much, Karina. It's fatigue is certainly a big issue, and then we don't unfortunately have magic medication for it. You mentioned modafinil too, of course, but unfortunately that's not on the PBS, so it's tricky and it doesn't work in everyone for sure. So now many of you know that we support research into MS at the University of Sydney, and I'd like to thank people who've donated blood samples to us over many years. Research is a very long and laborious task, but we are starting to bear fruit now, and we've now published three papers in major journals on the particular aspects of the immune system in people with MS and also with people who have been treated with different drugs using amazing new technology. The immune system is so complex. We originally first knew about T lymphocytes and then B lymphocytes. Now we have non-T and non-B cells. We have ILCs, we have NK cells, we have lots of other subtypes. And even within those major groups, we can dissect out different subsets of those immune cells. And we've been using a very powerful technique called mass cytometry, where we take your cells, we rush them down to Sydney by various means, and Pierre in our lab in Camperdown, he separates out the lymphocytes from your blood, and we do some experiments on the fresh lymphocytes, and other ones we freeze the cells and we come back to them. We're able to freeze the cells, so when we thaw them up, they're quite viable and they're still living. And this particular technique where we're dissecting out the complexity of the immune system is one where we use metal atoms and we conjugate these metal atoms to different antibodies that bind different targets on the surface of immune cells. And with this technique, we can put in the same tube 50 different monoclonal antibodies and separate out using this amazing technique called mass cytometry. Anyway, it's way too complex for me to understand. We've got some very bright young sparks down there at the University of Sydney. And the person and this is really an emerging science, just understanding how to, if you like, analyze these huge data sets. But we're going to put these 3 or 4 papers up on the website, and more are we're writing up all the time, and you can have a look, and it's pretty neat technology. So that's helping us hopefully to understand what is going on in your blood, which is making your MS active or your MS, if you like, not active, and we call that quiescent, so the MS isn't active. And some of the drugs we use now, amazingly, you can have the treatments and then having a couple of treatments over a year or a year apart, your immune system might then be turned into, it's almost like a remission. And some people have had treatments and have gone more than 5 years now after these treatments. So this is a sort of a start of a new type of approach to treating MS. And the holy grail, if you like, of treating MS is that we would like to turn off the disease permanently without you needing to take medication in the long term. So that's the sort of stuff that we're doing. But the other thing I wanted to briefly talk about was the glandular fever virus. So we're always thinking, what is the cause of MS? And for years now, the glandular fever virus, which is called the Epstein-Barr virus, EBV, has been associated with MS in the sense that 100% of people, virtually 100% of people who have MS have the glandular fever virus. But on the other hand, 95% of the normal people or people who don't have MS have the virus. So what is about the virus in people with MS? Is it really a causally related thing, or is it just that your immune system, the way it works, just makes it more likely to be infected? These have been questions that have been not able to be answered until very recently. And there was a paper in Science, which is one of the world major scientific journals, in January this year, towards the end of January, and was based on work done in the US Army. And when you go into the US Army as a young person, they take blood from you. Every 6 months, they take a blood sample. So what they did, they followed 10 million US military personnel over 20 years, 10 million. It's really quite extraordinary. And each of them had had a blood test every 6 months. And what they found was that over that 20-year period, and these tend to be young people, of course, joining the US military of all different backgrounds, they found that 955 people developed MS over that 10-year period. And they were able to go back into those people who developed MS and see when they had been exposed or when they developed the infection with the glandular fever virus. And the extraordinary thing was that when they went back to people before the MS actually developed, their glandular fever antibodies were negative. But when they developed the MS, their glandular fever virus antibodies became positive. So here we have a direct link that as the brain inflammation occurs, you've developed glandular fever. We knew in the past that if you develop glandular fever later, because most people, of course, who develop glandular fever develop it in childhood, but we knew that if you developed it later, it was a risk factor for developing MS. So here we can now quantitate it, and it looked like of those people who developed MS, there was about a 30-fold increased risk if you if you seroconverted, if you went from negative to positive to developing MS. Only one person developed MS who hadn't got any antibodies of glandular fever. So that was only 1 out of 955. So that's a hugely powerful indication that glandular fever virus, the Epstein-Barr virus. Actually, I knew Tony Epstein when I was working in Oxford. He's an amazing character. But anyway, here's the guy who first identified the Epstein-Barr virus. And so, that now raises the possibility that if we're talking about trying to prevent MS, that maybe we should be developing treatments like vaccines to give to all people so that they will have an immune response, so the glandular fever virus doesn't get hold. But Other people turn around and they say, well, I think we need to know more about that, because maybe we have such a high rate of glandular fever virus that our immune systems actually need it to make good responses in the long term. What happens with glandular fever virus, once you're infected with it, you have it for life. That's the interesting thing. It remains in if you like, a quiet form called a latent form in your B lymphocytes forever. So once you've had it, you've got it. And quite a lot of the immune system is actually aimed at targeting the glandular fever virus to keep it under control. But it tends to remain latent and not really a problem. But in other work, it's been shown potentially for the glandular fever virus to actually be in the brain, in lesions. So maybe some of the immune response is actually targeting the glandular fever virus. Maybe that chronic stimulation of the immune system is what you see with fatigue, cause of fatigue. We don't really know. But anyway, I think it's a question of watching this space. But this was a very important study, again, showing that glandular fever virus, the Epstein-Barr virus, might be very important to developing MS, maybe even maintaining it. And one of our neurologist colleagues, Dr. Pender, who's a neurologist, is now retired at the University of Queensland, spent all his life saying how important the glandular fever virus was. So he, in collaboration with some colleagues in Brisbane, have started treating people with glandular fever using their T lymphocytes that have been primed to attack the virus. So they've published, this is the very first paper that's ever, where people have started to think of actually focusing on the glandular fever virus and treating it. And that paper was quoted in this paper in Science of Michael Pender. So I think it's a question of watching this space. I think that you could think of a lot of reasons why that's probably not the whole story, because in the people that we're able to turn off their immune system, it doesn't seem that we're looking at any more serious problems with glandular fever. So people who go into longer term remission, whether they're on treatment, with continuous treatment, and after all, of course, we're hoping that 95 plus people, we can keep their MS under control. That doesn't seem to make the glandular fever more severe. So I think it's a question of watching this space, but I thought that was very interesting. So I think that's probably all I want to say, Karina, about research. Otherwise, I could talk for hours.
Sure. Yeah, that's so interesting. Well, we are coming to our close basically, but if you do have any questions, you can pop them in the chat. We'd love to see what you thought has been interesting, or what you're really curious about now. I might just start with a general question then, Professor Hawke. What are signs of a relapse?
Well, the signs of a relapse are very variable, and it depends where the MS lesion is, the area of demyelination, where the immune system is focused, the attack, if you like, on the central nervous system. So it depends. If it's in the optic nerve, you might have problems with your vision. If it's in the brain stem, you might have problems with dizziness. If it's in the motor system, you might have weakness. If it involves the sensory system, you might have numbness or tingling, or you might get unsteady on your feet. The important thing to say about that process where the immune system does cause damage, it's not something that varies much day to day. So people often have symptoms that come and go. If you're having an attack of MS, usually the symptoms are going to be present for some weeks. So day-to-day variability probably is not active disease. So that's important. That's an important point. But the other important point, of course, is, and this is why we do MRIs regularly, is that most of the areas of inflammation don't actually cause symptoms. So that's why to get an idea of whether the MS is under control, in the past, we just saw people and said, have you had any neurological symptoms? Now we know that's only a very small proportion of what activity there is going on in your brain if we look at MRI. So that's why I think it's very important to do regular MRIs on people. And as I said earlier, we're lucky to be able to do that. Oh, I should say that if you had a cold, for instance, or like your temperature goes up from a virus, you might get symptoms that you've had before. And that we think is related to a rise in your temperature. So if you get a fever, say whatever it's due to, say a urinary tract infection or a virus, it can bring back symptoms that you've had in the past. But that is because when the temperature goes up, the conduction of the electrical impulses in the brain through areas that have been affected by the MS is less efficient. It doesn't mean that you've got new disease activity in terms of the immune system being overactive. So you have to be aware that there will be sort of day-to-day variability. Even your neuromuscular fatigue that you spoke about earlier, Karina. I had a patient when I was a neurologist in London who they could only walk 200 meters. And after walking 200 meters, their legs went so weak that they collapsed to the ground. And then they would wait on the ground for about 5 or 10 minutes. And then their legs would strengthen up again. And they would walk another 200 meters, and then their legs would give way again. So that we think that's probably related to a slight increase in temperature and affecting the transmission of the electrical impulses if the temperature goes up. So that sort of underpins why it's important if you can try and stay cool, why people, we don't have baths, but one of the common features of MS in the UK was that when people had baths, they got a lot worse. So it doesn't seem to happen so much with showers. But even having an MRI scan can heat you up very slightly. So some people find that their symptoms might get a little worse. That's just a transient thing, a short-term thing. Don't be worried about that. An attack of MS is going to be present probably for some weeks. And, usually people will have symptoms for a few months before they gradually improve with relaxing, remitting MS.
Yeah. All right. Well, we have another question. Well, there's a few questions. Is the brain capable of repairing itself?
Yes, there's no doubt about it. And that's why I think that, many people after an acute episode of inflammation in the brain, an acute attack of MS, their symptoms often disappear. And that's because when the immune system goes into the brain, it causes a lot of swelling. And the lesions, if you look on MRI, are much bigger earlier on. They tend to shrink over time. If you're asking, is the brain capable of repairing damage that's been done over many years, so further down the track, I think there is probably a certain amount of repair that can occur. I mean, after a stroke, for instance, there can be improvement. And, I used to tell people who've had a stroke that you can improve for 2 years. And I think, people do improve even for 5 years after they've had a stroke. But are we able to rewire the damage that's been present in lesions that are older? Because we know that when you have a lesion in the brain, in the white matter of the brain, where the wires are connecting different brain regions, you can lose about 60% of the wires that go through that area. So that's why we don't like new lesions, because the more lesions they have affecting the wires in the brain, the less efficient will be the if you like, the communication between one brain area and another. And that's what tends to make MS worse in the long term. So we like to be quite aggressive at stopping the inflammation. Can there be repair to those areas? I think no. And I think it's going to be a long time before we're going to be able to repair those, what's the wires that have been crossing those lesions. If you look at many of the lesions further down the track after they've occurred, you end up with just spinal fluid, cerebrospinal fluid. So it's basically like that piece of brain has disappeared. And luckily, the lesions are usually very small. So as long as we can stop new ones forming, we can be very confident that we should stop people getting worse. But there's no doubt that the more lesions you have, the more likely further down the track you might get a little worse. And we think that could be related just to loss of the wires, because we're all losing brain cells, unfortunately, after the age of 25, and I'm afraid to say. So we want to try and preserve our brain cells. So that's certainly something that we need to look at. How do we preserve brain cells? And we might get information from other diseases like Parkinson's, because we don't really know how to stop brain cells dying off too quickly in Parkinson's. So we should keep an open mind. I mean, one of the recent advances in Parkinson's was realizing that fruits containing anthocyanin, which is blue pigment, which is an antioxidant, might slow down the progression of the disease. So that would suggest that any disease where brain cells are dying off, maybe even normal aging, we should try and eat some foods that contain anthocyanin, probably greatest in blueberries or those blood plums. So this is something that's coming from epidemiological studies in another disease that potentially could be useful. So I think, there's a lot to be thought about diet and impact. Oh, somebody's actually asked that. Stacey, I can see. Yeah. There's a lot that we should keep an open mind. So, the keto diet, for instance, if you look at experimental models of MS in mice, for instance, if you put mice on a ketogenic diet, you can never get brain inflammation occur. It's really quite dramatic. So there's all sorts of other factors that might modulate the immune system, and might help, the therapies that we're using, the drugs, work even better.
Yeah, there are some more questions. We'll just have one more, because I think we will have a few more webinars, and I think diet is something that we'll try and cover more on. But this question is, what are the indicators of moving to secondary progressive disease state? Is it more lesions or a decline in physical capacity shown by clinical presentation?
I think it tends to be where the lesions are. So if you look at a large group of people with MS, and you look at people who've gone into a sort of secondary progressive state, in the past, that was due to, firstly, having a lot of lesions. So getting more lesions is a bad idea, generally. But now we're so good at turning off new lesion formation, do people still slowly get worse? So how does that work? And then we have primary progressive MS, where people slowly get worse, but they don't usually have that many lesions. So, and that's probably why the drugs don't work. It's a very unusual disorder, primary progressive MS. It's quite uncommon. It's certainly way less common than if you read about it in textbooks. It's nothing like 10%. I'd say it's 2% or less. So what are the indicators when people get worse? Well, usually it's their symptoms getting worse. So if somebody does think their symptoms are getting worse, is it because the medication's not working? That's why MRI is so useful. We can do scans and we can compare them, and we can say, hey, no, I don't think it's due to you getting more lesions. Then we have very potent drugs. So if you look at, for instance, people who are taking Tysabri, it pretty much stops new lesion formation. Well, other drugs do too, but it's very, very effective. And yet, people who've had a lot of lesions over time can get worse. And my own view, and not only my view, because a lot of people have the same view, is that it's related to the fact that there's been damage to the various pathways. It may be because if you think about it, if I move my right hand, I set up impulses, electrical impulses in the left side of my motor cortex, which is about here. And when I think of doing that, the motor system, the pathway, it's like a cable connecting the thought process, going down through the deep parts of the brain, through the brain stem, down into the spinal cord, and then going from nerves in the motor nerves to hit the muscles of my hand. So there's a very long pathway to get my fingers moving, okay? You have to contract these muscles around the elbow. So if that long motor pathway has been affected by brain lesions in the spinal cord, in the brain stem, in the brain itself, then there'll be fewer wires, if you like, connecting the motor pathways. Now, as we get older, I think probably we might lose 20%. We still have 80%, and that's perfectly good. We have this safety margin. And so that means that, we don't usually get weakness as a factor of getting old. There are other parts of the nervous system that maybe do become more sensitive to getting old, and that's balance. But if you've lost 50% of the wires because of lesions that have occurred from the MS over many years, just losing wires, each wire you lose potentially might have a significant effect on your motor function. So I don't think just getting worse is necessarily due to activity of the immune system. And I think that what I've just said could be an oversimplification, and it might not affect everyone, but other people think that it could be because the immune cells have got into the brain, and we're not very good at identifying the presence of immune cells, and the drugs may not affect the immune cells so much in the brain itself. That's a theory. That's why the MS Brain Bank is very important, for people to be able to study what's going on in the brain at the end of life, because you do often find there is still some inflammation there. But I think that in most cases, getting worse as you get older is probably age related. We can't reverse aging, unfortunately, but we might be able to maybe in 10 years' time, who knows?
Yeah, thank you. Might just get you to tell me your quick thoughts on the Walls protocol. I know that's an MS specific diet. Do you have any quick thoughts on that?
I don't. Do you?
No, I think they're doing more research into it. I know it's a very strict regime. It's like very limited portions. So, yeah.
Well,
but we're looking.
The ketogenic diet is if you're going on a keto diet, and you measure ketones in your urine, you have to have extremely rigorous, and maybe that's part of it. I don't know. I don't really know the Walls diet, but
yeah, it's very restricted on carbs and
that sounds like keto.
Yeah,
it's not.
Sorry, you go.
It's not particularly restricted on carbs, but it's very good, but it is strict, like you're saying. But it's a lot of natural, well, not natural, but whole foods. It's all about eating whole foods, and we're not very good at it because it's not very fast.
It
does work though.
Yeah, so I think it's very limited on your meat intake as well, isn't it? I think
It depends on what level you go. So there seems to be different levels that she's developed.
Yeah.
And the basic principle is to eat 9 cups of fresh veg a day, and it has quite a high ratio of green leafy greens in that. And it's good, but it's very hard to follow.
I mean, I think in general, a lot of nutrition is about eating more whole foods, less processed foods, less refined sugars and saturated fats. So, but we'll definitely, sorry, you go.
I'd say one link between diet and the immune system is the effect of diet on what we call the gut microbiome. I don't know if people have heard about that, but we're doing more and more research into that. There's a whole institute at the University of Sydney devoted to the gut microbiome. And already we know that if we look at what bacteria that you have in your gut, it can be substantially altered by different foods, and they may be relevant to activity of the immune system. So yeah, I think it's a watch this space. I keep an open mind. I think, look, when Dr. Hammond retired, a lot of his patients, seemed not to have any ongoing disease activity. And that everyone got an MRI every 12 months. And you might say, well, that's they seem very well. And you might say, well, that's because they didn't have many lesions. But I can tell you that some people, their disease seemed to be very active early on, and then in the absence of any treatment, seemed not to be active. And so we have this idea of benign MS. So we're quite interested in that with our research, trying to understand whether or not the immune system has changed. And maybe diet is relevant. Maybe it's that you've been infected by another virus, which has actually turned off the autoaggressive part of your immune system. There's some evidence that certain worms, for instance, can mount a response which is protective, and they've done studies in South America looking at benign worms and changing the immune system as a treatment for MS. Anyway, I think it's watch this space. Fascinating stuff, but it could all be very important.
Definitely.
Yes.
Well, thank you so much, everyone, for spending an hour with us. I hope you did find it helpful, thought-provoking, and we are planning on having at least 2 more webinars later this year. So do send me your questions or things that you'd like us to cover, because we definitely want to make it as relevant and practical as possible. All right, thank you so much, Professor Hawke.
Good to see everyone. Thanks
See you later.
Thanks for listening.